This is HeartRhythm TV. I'm Oliver Manfredi, and I'm delighted to welcome Dr. Avi Fischer from Orchestra Biomed, where he's the Senior Vice President of Medical Affairs and Innovation. Dr. Fischer, welcome to HRX.
Thank you very much, Oliver. It's a pleasure to be here, and thanks for taking the time to set up this chat.
Yeah, I mean, HRX is all about innovation. And that's why I was so keen to get you on here, because, you know, we're used, as EPs, we're used to implanting devices for Brady indications, for tachy indications, for resynchronization indications. But you've developed a technology that is device therapy for hypertension. And I wondered if you could tell us a little bit more about that.
Sure. I'll start by saying, it's a really amazing time in the world of electrophysiology, with everything going on the ablation side. But also the excitement within the device community for things like conduction system pacing, and for thinking about the use of pacemakers for conditions and disease states that are perhaps not traditional. Mm-hmm. And so you're correct. So Orchestra Biomed, we have developed, we have a technology that is referred to as AVIM, atrioventricular interval modulation pacing. And the therapy is pretty much what the name suggests. We modulate the AV interval during dual chamber pacing. And as you suggested, we're doing it as a treatment for hypertension. And the therapy is novel, and I must say it's investigational at this point, so it's not commercially available. But it was specifically designed to have an immediate effect, to have a substantial impact on blood pressure reduction, and for that reduction to be persistent, sustained, and durable over time. And the technology leverages really fundamental concepts in cardiovascular physiology. The Frank Starling law that we're all familiar with, the relationship between pressures and volumes. Mm-hmm. And the way atrioventricular interval modulation works is we continuously deliver sequences of short AV intervals interspersed with longer AV intervals to have the effect. And each of those types of intervals have a specific role. The short AV intervals shorten diastolic filling time and immediately drop preload. And that leads to an immediate reduction in blood pressure. We see it within the first beat or two after initiation of the therapy. Wow. Now, in order to modulate the autonomic nervous system response, the Barer reflex that we all have and is the normal physiologic response to reductions in blood pressure, we introduce cycles of longer AV intervals, where the blood pressure rises to levels that are more normal. That leads to modulation of that autonomic nervous system response to the reduction from the short AV intervals, ultimately leading to afterload reduction and a durable, maintained, sustained reduction in blood pressure.
Wow, that sounds remarkable. A real innovation. Maybe you could take us through some of the early data supporting the use of this particular technology.
Sure. So, like many innovations, there was sort of a sequence of studies performed. Mm-hmm. Obviously, preclinical studies, feasibility studies in humans, single-arm studies, and then a pilot, dual, multi-center, randomized control, double-blind study, which was performed on 47 patients. The primary endpoint of the randomized study, and in that study, we had the ability to compare the effect in a control arm versus a treatment arm. And we had a reduction at the 6-month primary endpoint. And this is a reduction as determined by the gold standard, the 24-hour ambulatory systolic blood pressure monitor. We had an 11 millimeter of mercury reduction in ambulatory systolic blood pressure at 6 months.
Wow.
And a between group difference, because the control arm in hypertension studies, we know this very well, even from non-device based studies of hypertension. The control arm had a small decrease in blood pressure as well due to participation in a clinical study.
Absolutely.
The between group difference was about 8 millimeters of mercury reduction favoring a treatment arm.
Right.
And importantly, the safety profile was borne out. There were no signals of increased safety events in the study, and a very, very favorable safety profile and a very high rate of response in the cohort of patients.
That's really interesting, because I presume that you're kind of with short AV intervals, you're forcing patients to pace their ventricle, and presumably this is ventricular pacing from a standard right ventricular apical position. So is there was no signal of pacing-induced cardiomyopathy in any of the patients, or
no? Great question, and timely question, right? The time that some of these earlier studies were performed predated the momentum that we now see in the EP community for conduction system pacing.
Right.
So these patients had RV leads placed, in positions that were non-conduction system. Importantly, as we think about pacing-induced cardiomyopathy, there are a number of things, a number of conditions that predispose patients to developing pacing-induced cardiomyopathy.
Sure.
One of the most important is the existence of LV dysfunction at baseline. And all of the patients that we have enrolled in our prior studies have had normal LV function, LV function greater than 50%.
Yeah.
Now, having said that, we have some very compelling data, and there's a publication now in JACC EP that is available, where we did pressure volume loop analysis, both after acute therapy, as well as non-invasive pressure volume loop analysis after chronic therapy delivery, really speaking to the hemodynamic effects of the therapy, where we demonstrate both, by the way, with traditional RV lead pacing, as well as we included conduction system pacing in this study. And we demonstrated the impact where we not only decrease blood pressure, but mechanistically, we're decreasing intracardiac volumes and pressures. We're not impairing contractility. And we are actually providing a favorable state of energetics as we were able to demonstrate by a reduction in stroke work.
That's really impressive. And how about its tolerability? You know, how do patients feel with their AV interval being modulated repeatedly through the course of the day? Does it cause a decrease in quality of life at all? Or?
So from what we've learned thus far in the patients we've studied in a number of different constructs of studies, patients do not complain, do not know that the therapy is being delivered. But you asked a very important question, because we're currently enrolling patients in the Backbeat Global Pivotal IDE study. And one of the pieces of data that we will be collecting and looking to learn from, we will be administering quality of life surveys and trying to better understand the impact of the therapy, again, not just on hypertension and hypertensive heart disease and some of the associated conditions, but really from a quality of life perspective as well.
Absolutely. That's a nice segue into my next question, which was, I was going to ask you to bring us up to the current day, you know, the AVIM therapy. Where are we today? You know, where's the Backbeat study? How fully recruited is it? And where are you in terms of analyzing that data?
Yeah, so great question. So let me start by saying, you know, the Backbeat study, it's an IDE study. Orchestra Biomed is the sponsor of the study. We have a partnership and a relationship with Medtronic, where this is ransomware that will be put into commercially available devices by Medtronic, rendering those devices investigational. And so again, this is a joint effort and partnership between Orchestra Biomed and Medtronic. So we are actively enrolling in the Backbeat Global Pivotal IDE study. It's being conducted in the United States and Europe right now, and potentially some other geographies. I will say that I'm not at liberty to say anything more about how things are going, other than to say that we're making real progress in enrollment in the study.
That's great.
And we're really looking forward to fully enrolling the study and having very impactful and meaningful data moving forward.
It's a really interesting study design, I think. I don't want to get too deep into it, but you know, I think that you randomize the patient, if I'm correct, to having the therapy on for a year, off for a year, and then the patient then gets to decide, right, for a spell after that.
Yeah,
Sorry.
so almost right. No, so you're almost right. So yes, the blinded phase of the study is 1 year. So there's a 12-month blinded phase. After that 12-month blinded phase, we will open label and allow for crossover. And then we'll continue to follow those patients more longitudinally and collect more longitudinal data on the impact of the therapy. Again, as I mentioned, not just on hypertension, but on things like heart failure, AF burden. I mentioned quality of life and other important indices. We hope to answer many questions about the therapy. And we really are thinking about the therapy. We talk about hypertension, but really we should be talking about hypertensive heart disease.
Right.
Because it's a continuum.
Absolutely. I think it's a really neat study design. My last question is, where do you hope the therapy is going to be in 10 years' time? Is this the kind of therapy that's going to be an algorithm in all devices? Is it going to be proprietary only in Medtronic devices like reactive ATP, for example? Or is it going to be generalizable, do you think?
So that's an easy question to answer. So Medtronic is our exclusive commercial partner.
Okay.
As I mentioned, we have a unique and strong partnership with Medtronic on this program. So where do we see this in the future? Well, so in 5 years from now, hopefully this is an approved technology. I do want to say we've already received breakthrough device designation from the FDA.
Okay.
And importantly, the breakthrough device designation actually encompasses a much larger patient population. Again, thinking about hypertensive heart disease. So the breakthrough device designation that we received from FDA points to a couple things. So patients that have blood pressure that is out of the target range, so uncontrolled or out of target high blood pressure. Patients need to be high atherosclerotic cardiovascular disease risk, which for the most part is encompassing older patients with hypertension, and specifically isolated systolic hypertension, which is the predominant form of hypertension in older patients. The third requirement is normal left ventricular function, so LVEF greater than 50%. And then, we touch a little bit on conduction system pacing. And obviously, as the field is migrating, conduction system pacing will be part of the story as well.
Sure.
And so if you think about where this will be in 5 years, and I've had many conversations with electrophysiologists, again, who, no disrespect, right? I'm an electrophysiologist as well. We don't spend a lot of time thinking about hypertension, right? So for the EP who says, well, why should I care about this? It's hypertension. It's because hopefully in 5 years, there may be a whole new set of patients for you to implant with dual chamber devices, where the requisite for the presence of conduction system disease, sinus node dysfunction, AV node dysfunction, is not even part of the story, right? Because the breakthrough does not require a standard pacing indication. So it's a really exciting time, as we started in the beginning of the discussion, to start thinking about other disease states and conditions and leveraging bioelectronic therapies to address some of these really challenging and hard to treat conditions, where we can take the requirement of compliance out of the equation. This operates in the background. The patient need not do anything, right? And this is an adjunctive therapy to pharmacologic therapy, and hopefully in 5 years, this is another tool in the toolbox as a primary treatment for patients with difficult to control hypertension despite pharmacologic therapy.
Well, really phenomenal, fascinating technology. Thanks for giving our viewers an insight into that today, Dr. Fischer.
Thank you.
I appreciate you having a chat with us.
Thank you, Al.
Nice to see you.
Great to be here.
Thank you, sir.
Thanks for the time.
Appreciate it.